I don't even know where to start, but I'll start with asking the responders, the panelists, to please join us on the stage. And Dr. LaVeist, there is a chair for you to also join them. And we will have our discussion. This is a time when there will be folks handing out evaluation tools. We really need you to evaluate this conference. For those of you skating out the door, you'll be stopped because we do need an evaluation so we can determine what we do in the future. As well, I'd like to take this opportunity to just acknowledge the gentleman who's in every picture with every community partner, and that is Brunel. Is Brunel in the room? We're going to give him a hand anyway. Brunel was responsible for an extensive amount of the recruitment of our community partners, and we can't do it unless we really have people who can go into our communities and engage those that we would like to help. Okay, so now we have, I'm going to go from your left. We have Dr. Ford. Dr. Ford is he is the medical director at Brooklyn Hospital. Please give him a hand. I'm getting your energy back up. We have Dr. Tracey Wilson. Dr. Wilson is a professor in the Department of Community Health Sciences at SUNY, and she is a part of the Brooklyn Health Disparities Center. We have Ms. Tong, and Virginia Tong is the Vice President for Cultural Competence and Partnership Integration for the Lutheran Healthcare System. And of course, you know, we have Dr. LaVeist. So at this time, what we would like to have is response to Dr. LaVeist's presentation, which I have to tell you, I'll be thinking about this for weeks to come. We also would like questions, but we'll give the responders an opportunity to respond, and then we would like you to give us questions and to engage you in this discussion, because after all, this is what this is all about. So, Dr. Ford.
First let me say it's always great to hear Tom talk, because he has the ability to crystallize messages from data and really drive home some very important points. And as I thought about doing work that ultimately impacts the health of the community in Brooklyn, it became very clear that throughout my career as a doctor, what was always a challenge that we acknowledge and then we keep going and do the same thing we always do. The challenge is that the patients who come into our office and that we all see, they may look the same or they may look different. And the bottom line is that they go to different environments after they leave. And how it is that we treat them, the outcomes are going to be shaped not just by, whether the drug is going to land on that receptor, as you were hearing, but also it's going to be determined by the social environment that the patient lives in. So from the perspective of delivering care, it is very clear to us that we have to get better at designing ways to address treatment of the patient's condition in their social environment. So that has been the focus of the initiatives that we're trying to develop here at Brooklyn Hospital. And so what we're trying to do is to understand the communities that our patients live in Brooklyn, working with people from the communities to not only identify what are the public health model or a medical model might say, hey, you have a smoking problem here. But in reality, if we can develop solutions that are focused on the problems that the community identifies, it is more likely that the solutions will be sustainable and that the partnerships that are necessary in order to really develop and deliver solutions, those partnerships will be more likely to survive. So anyway, I know there are several other people to comment, plus the audience. I'll stop right here.
Dr. Tracey, well,
so I want to thank you for opening up your talk with the big question.
Dr. Wilson, can you bring my
microphone? Yes. Thank you for starting the talk with a big picture question. Imagine. Can you imagine a world without health inequities? And do you want it? And if you do, that really takes away a lot of differences between all of us who work together in this area. So I want to thank you for doing that. And Dr. Bassett also talked about moving away from a trickle-down approach to eliminating health disparities and health inequities and making it more of a central forum for what we do, putting it in the center, and I think away from the margins, which is a lot of what you spoke about. So to me, that framed the discussion from an education point of view. And the question that I asked myself when you went through so much, so very much, but you talked about responsibility, you talked about your assumptions that you walked in, you talked about the importance of designing and interpreting our work responsibly and accurately. The question for me is, are we doing then what we need to in terms of education? Educating our students in public health, educating our medical students, our future health professionals, so that they can be seeing the bigger picture. I think that's a question for those of us who are patients. It's a question for those of us who are educators and researchers. And is there anything that we're missing here that we need to be doing better? I would pose that to all of us working together on these issues.
Ms. Tong.
Hi, thank you for really a very interesting and eye-opening presentation. I think all of us who work in the community and in medical settings are always relying very heavily on the data, and I think it's been very eye-opening in terms of how we interpret that data. One of the things that in our community we are always looking at, Lutheran's located in Sunset Park, and so we serve a predominantly Lutheran community, is that we have no data, and oftentimes in our communities, and so our struggle has always been to have data, to have research, and so on, but I will also be the first one to confess that I have participated in that research that well, we learned something. Something that we did with the Arab population in Brooklyn, it's the largest Arab population in New York City. We tried to do a health needs assessment, and together with the community partners and so on, and thought of every possible cultural and ethnic component, and came to find out that one of the things that we had to do was talk about hookah smoking. We had a question about smoking, okay, and we were very surprised to find that our findings were very low, that the incidence of smoking was very low. But when we analyzed the data, we realized that we really should have asked the question about hookah smoking, which in many parts of the community is not considered real smoking. They consider it as tobacco smoking. And as we know, many more dangerous in hookah smoking than in tobacco smoking. So I think that one of the things that, besides the idea about looking at data, which in many of our communities need more data, and hopefully the idea is not only to do research, but to continue to do it. So if, my data shows that, smoking was low, we should do more, okay? Because we should find out, we should have follow-up studies about who was smoking, okay? And so on in that community. The other piece of it, like I said, as was spoken by numerous speakers, was about partnerships with the community. Our hospital would not, our health system would not exist if it were not for working with the community. Our partnerships with the community are what make our outreach to the community as successful as it is. It doesn't end there. I think one of the things that we are looking for, we spoke earlier of resources, is that with the Affordable Care Act, of course, we're hoping that resources are more equally distributed. However, we are also concerned again that not only are undocumented residents not included there, that even those who are documented, whether they have taken advantage of the advantages of the Affordable Care Act, whether they in fact will use it. We are a safety net hospital, and one of the concerns that we have is that if my copay is $50, will I be able to do that? If my deductible is $3,000, will I still come into services, or will I still be using a safety net? So I think that the discussion about resources being important, I think that's while our hopes have been about the Affordable Care Act, I think there's still more to discuss. And then the last thing I wanted to talk about, to add to the whole discussion, was empowerment. We talked a lot about the community being empowered. And we talked about how we have collaborations between government and community and academia. I think with the community piece, one of the things that comes up time and time again is that we're not empowered unless we're politically empowered, that many of our community members don't vote. And when that happens, we see the results of that. So I would put that out there as well, that while we are looking at our community needs to take a stand and needs to vote in order to make sure that our voices are heard. Thank you.
Any questions?
Thank you very much for your presentation, Dr. LaVeist, and for the discussants. My question is to you, Dr. LaVeist, and anyone else can chime in. I too am a little bit concerned, or a lot concerned, about the focus on publication, particularly with centers such as we're in today, and their interpretation that it is NIH or whomever the big funder is, it is their thing that the center should be publishing. My question to you is, what do you think communities can do to impact, challenge, whatever the word is, funders, big funders like NIH, to think about how they put out their RFAs or whatever, that centers interpret this to be focused on publication at the expense of outcomes, impact on community.
Wow. Hello? You hear me? Okay. No, this is working. So that's a really tough question. I wish I had more time to think about it. But so I think that relationships, university community, hospital community, these relationships work best when everyone understands the drivers, the things that cause the other to have to. In other words, what are the things that motivate the behavior, right? So if the center here is focusing on publications, then the partners need to try to understand what is it, why is that a need for them, and what is it that drives that need, right? Just as the people at the center need to understand the community and say, okay, what are the things that's driving people? What are the influencers that make people do the things that they do? And that has to be a two-way street. It has to go both ways. So as far as the university-based people needing to publish, publication is the form of currency in academia. It is the thing. It is the money. It's the thing that's traded. It's the thing that creates opportunity, because if they don't publish, they're not going to get the next grant, and they're not going to be around for, in the future. And why is NIH pushing publication? Well, there are politics there too. I'm assuming this is NIMHD funded center. Is that right? All right. So this center is funded by the National Institute of Minority Health and Health Disparities. And since I'm a visitor here, I can speak plainly. There are politics. The National Institute of Minority Health and Health Disparities is the newest institute. There was a lot of political opposition to even creating it. There were many who didn't feel that that institute belonged in NIH, that it sullied the pristine reputation of NIH. So if NIMHD is giving grants to organizations that are not publishing, which is the thing that's valued at NIH, then this is going to fuel the opposition to that center to that institute existing. So the chain of events is, if the center here at Downstate is not publishing, they're going to lose their grants in the future. If the centers that get funded by NIMHD are not publishing, then NIMHD is going to cease to exist. And then once that happens, then we go back to a time when there was nobody at NIH, nobody in the federal government that owned minority health and health disparities. So it's imperative that they publish, because that's just the reality of the factors that influence their existence.
Could I add one comment to that? I also think there needs to be reform in schools of public health around publishing tie-ups with tenure and promotion. And schools of public health need to recognize that to do good community-engaged work takes longer often than doing many other types of research projects and trials. We spent how many years developing the barbershop talk project so that we could do the formative work that was really important. If I was a little younger in my career, that would have been challenging because it took years to get the publications out, but now we have a program that we feel really is replying to needs in the community, that's community informed, that's acceptable, and that is feasible. So there's this tug there that's not a good fit yet. There needs to be some thinking about this issue.
I would agree with that. But let me just make one more comment about that, about the publication things. So I kind of challenge the community partners to understand what the university people have to do, because that is part of their reality. But now I'm going to challenge the university people as well, that we have to go beyond just publication. We have learned a lot in the last 20 years or so. We have learned a tremendous amount about how to address health disparities. But it's all locked away in the library where few people can access it. And we need to go beyond just publishing the academic articles, and we need to start communicating to people. I'm not even going to say the community. We need to communicate to people. We need to communicate outside of the academic world. We need to find, other ways of publishing, other ways of getting information out, other ways of getting those messages out.
Oh, thank you. I really want to thank you very much for your extraordinarily useful and wonderful presentation. And the whole morning, I've found the attention to the community's voice to be just very, very meaningful. This question comes as a 50-year practitioner of general internal medicine, primary care, last working for Dr. Ford at Brooklyn Hospital, and in mostly, though, areas that are on the unequal side of the healthcare disparities, I guess. And one of the things that I've come to appreciate or to think about is, I'm glad you talked about the individual practitioner or the individual patient, what they bring to this equation, which is often, healthcare is an individual model. It's an individualistic model, so that your personal failings of blaming, shaming, having diabetes, having obesity is a very disempowering kind of understanding, but it's embedded in our individual healthcare model. And how do we think about bringing all of what you've learned and what we're talking about today into that understanding, because I think it really does hold people back. I run community conversations on health through a not-for-profit, the All-Stars Project that I work with, where we talk about these things all the time, is how's our understanding about poverty, race, all of these things, lack of opportunity affecting our understanding of our individual health problems. And I think it's a big gap that the macro level understandings and the individualistic understandings.
I'd like to speak to how it is that we are thinking about approaching this. We don't know the answer, but what you've heard from all the speakers here, including from Lutheran and all the examples that everybody gave, is that in order to really improve the health of a community, you really need to understand local data. And what we haven't really done well is to apply knowledge of local data as they affect those patients who come in to see us as individuals, so that we can develop strategies that really address the needs of patients in those small areas or small in their social environments. And what we're doing in what is called the Health Situation Room, and this is a project that we're collaborating with a colleague from Hopkins on, with Carlos Castillo Salgado and others, is to first develop epidemiologic profiles of different areas in Brooklyn. You know, our catchment areas, northwest and central Brooklyn. And then what we're hoping is to work with community partners to really enrich those profiles based on more information about those environments beyond what we can get from the census, data on traffic and community violence and so forth, to begin to map out where people live, what is their experience after they leave the office, and the long-term vision is that we would be able to begin to develop solutions that are more tailored to the individual patients. It's a really challenging activity to think about, but that is what we're trying to do. We're lucky to have recently been funded by the state through the Vital Access Program to develop those profiles and to begin to better understand the interaction between the social environment and the care that we deliver for a number of different conditions.
I just want to add also that in looking at community and in looking at, you know, how to apply that knowledge to the individual practitioner and so on, I agree completely in terms of we really have to look at individuals as whole people, that they come with whatever their culture, their beliefs, their values, and so on, and so that, you know, to kind of try to paint a brush and say we're all, you know, all blacks, all white, or whatever, all the same is really a disservice. But I think the knowledge that comes from, albeit bad research or bad data, that if known, can be passed on to practitioners, can be used so that you can, you know, move on. So that my bad research that says, you know, forgot to ask about hookah smoking, when that is passed on to an individual practitioner and you're in that, you know, medical exam and you're doing the, you know, history of arthritis, rheumatism, whatever, smoking, oh wait, hookah smoking? You know, not just tobacco smoking, but hookah smoking, so that is passed on. There's value. I think there's value to it. So I don't, you know, to combine what was said earlier about, you know, producing publications and so on, if that publication is available to the community, which I agree with Dr. LaVeist, we don't always get that. You know, on the community level, we don't always have access to that data. So whatever data we can get can be used and transferred into knowledge and good practice for, you know, people in the community.
Just a minute. I'm sorry, just one moment.
No. Thank you so much for this panel. My name is Dr. Dees from Downstate Medical Center. I came here in 1958. There were 2 black medical students in my class. Leo Stewart was Phi Beta Kappa from Howard University, and myself. People were dying from hypertension, malignant hypertension. At that time, we had no drugs. We had no drugs for hypertension until 1955, when hydrochlorothiazide was the first drug that showed any hope to bring down the blood pressure. The thing that I'm saying is that we know blood pressure is related directly to salt. But when people talk about salt, we're not talking about table salt. That's sodium chloride. We're talking about soda that you drink every day is sodium benzoate, sodium bicarbonate, monosodium glutamate. It's sodium. And how that came about genetically, because of slavery, the slaves sweated so much in the bottom of those slave ships, their genes did change to retain sodium to keep the blood pressure up. And that's why we're so sensitive to sodium. And yet, we'll have every drug, and yet we're not controlling the sodium. Sodium is almost in every compartment thing you want to find around. I'll give you another example. Argo laundry starch. Argo laundry starch was eaten by thousands and thousands of black women, causing iron deficiency anemia. In fact, when they ate Argo starch, their hemoglobin was 8 rather than 12 or 14. And no one, and you can read it in the literature, attacked that whole thing of the eating of Argo laundry starch. And our black women were having hemoglobins of 7 and 8 rather than 14 eating laundry starch, and also clay in the South. So we attacked that, Bill McCurry and I, on the Channel 5, which is a very racist station also. But he became a commentator and he brought me on in medicine. Do you know we don't have any black male doctors on television throughout this whole country, on television or media? We have no male black doctors. We have few female that have on panels, but not male black doctors who have a whole bunch of stuff. But the whole thing is that it is education, but it isn't going to, you know where the education is going to have to take place? On Sunday morning in churches. Not just for the Sunday, just to have a little program. I'm talking about from the pulpit, because that's where the concentration of black people are at. It's on Sunday morning throughout the country. So we have programs that are used, but they're not doing anything. We still have the same malignant hypertension going on. We have the same below-knee amputations because of diabetes. Where do we end this? It's not racism. It's getting the information across to people in a way that they understand. And oftentimes it comes from the pulpit. If the pulpit says something, people will come in line. But if you just have all the health fairs you want, it's not going to take place. So I'm just saying that I appreciate a panel on disparity, but it's up to us as black doctors. And we're not producing enough black doctors. Do you understand? That's throughout the country. In fact, even Oprah has a Dr. Oz. She had the opportunity to have a black doctor on her program. Do you know what that meant? To have a black doctor on Memphis program? Where she could have other black doctors, female and males, to come on and talk about the problems, but yet we still look at that program. So these sparse radio shows, TV shows, and all these crazy TV shows, or the hip-hop, listen, hip-hop ain't gonna make us change. Hip-hop, the hip-hope. You can hop it so high. Hope E will make your mind fly, hope. But the thing is that we're having the same conferences constantly, and it's not happening. But when we attacked Argo starch, if you look at that thing on the outside here, on the thing, in 1985, Bill McCurry and myself, we hit Argo starch. We put them out of business from Argo, Illinois. They are no longer making Argo starch, and women are not eating it. So I'm just saying that if you can hit health issues like that and make a change, it's just rhetoric otherwise. All these drinks that the children are drinking, the quarter water, those little colored drinks, they're out of business because we went on the media and took them out of business because those drinks were causing high sugar, additives, dyes, and that's all it was. But it looked like fruit. Well, you know why it looked like fruit? Because it was sodium metabisulfite. They had to put in those drinks to stabilize the colors to make everything look colorful. But the sodium metabisulfite was causing asthma in our children. And so when I went to schools and hold that bottle up, I said, how many of you children want one of these drinks? Everybody raised their hand. They were drinking it every day. It's called quarter water. But they're out of business also because we had a bill passed that you couldn't put sulfites in those drinks to stain the colors and look like fruit. So the company's out of business. So children can't get those old drinks, in a sense. So I'm just saying that there's 1,000 of these things that if we're going to control health issues, it's not going to be on the basis of just laws. It's going to be the basis of putting businesses who are doing these things and get them out of business. Benjamin Feingold showed 50 years ago why children are acting silly, in a sense, cutting up, can't memorize, irritable and so forth, of additives in foods. And when I go to those conferences, I don't see black people, pediatricians or psychiatrists. You know why? Because Ritalin took over. And Ritalin was controlling all that behavior problems and things like this, not realizing it's all in the foods. So if the FDA can't be brought into this whole picture to rule out a lot of these things, you can forget to try to get the people to participate. Thank you.
Okay. So Dr. Dees became a part of our panel. We're going to take, and we thank him, you know, Dr. Dees, we know we do thank you. We can only allow 1 or 2 more questions, but they must be limited now because we have to let our panel go. Okay, so there was one question in front of Dr. Dees, and if you could limit it so that we can get some response. And remember, there is lunch that will be served following this. There will also be the evaluations that you must complete, please, before you leave the conference. Okay.
A cancer called multiple myeloma, which mainly affects the bones, for approximately 10 years at Downstate, both at the University Hospital and at Kings County. Although treatments for myeloma are available, median survival remains 3 to 7 years. So there is more and more data coming in from reputable sources that multiple myeloma is seen 2 to 3 times more in patients of African background. And this is not just Africans who are born in America, but Africans born in Africa and people from the Caribbean. Our myeloma population here is 99% originating from the Caribbean countries. And we see there is a high-risk population for myeloma, which makes up the shorter lifespan people. And we see approximately 30% of those patients here. The new so it is a disparity issue, the multiple myeloma disease. The new literature shows that myeloma is always preceded by a precursor state. What is new is that we could screen for this precursor state and we could tell who is going to develop into myeloma or not, except that only approximately 2.7% of those who screen positive will develop the disease. And there's really no reason to upset or to alarm the rest of the patients who test positive for this.
So, Doctor, I just need to know if you have a question for the panel.
My question to the panel is, how would we go about screening this in the community? How would we make a community aware that there is a multiple myeloma threat, that they don't need to be scared, but nevertheless, we need to screen existing blood samples, and also going progressively, we need to screen patients. If this is an inappropriate question for this panel, don't hesitate to let me know.
Well, I think it is an appropriate question, and multiple myeloma is a very important condition for the reasons that you talked about, and we don't have enough data to understand its determinants, and that makes it difficult to prevent it, therefore. And moreover, as you mentioned, even if you detected it early, even if you screened and you identified the pre-myeloma state, it's very difficult to predict who is going to go on and develop the disease. So I think that what we really need is to have research going on in communities such as this, where you have basically a large African diaspora to try to understand what are some of the determinants of multiple myeloma. So we better understand, perhaps what the drivers might be difficult because the environmental exposures are difficult to measure, but at least beginning to do some clinical epidemiology to understand what the predictors are. In fact, one of my fellows, we just published something about some of the predictors, some of the tests that are used, some of the screening tools, and frankly, we're very far from where we need to be.
Okay.
But we need to do the research to understand it better.
So people that are not of African descent get multiple myeloma as well. So how does it benefit? What's the benefit of tying that disease to people that are not of African descent also get this condition? So the question is, what is the benefit to tying it to African descent? We have certain conditions that we've done that for, and it hasn't always been a good thing. For example, my brother's a journalist who wrote an article some years ago about white sickle cell patients and how difficult it is for them to get a diagnosis because they would present with classic symptoms, but people would say, well, they're white, they couldn't possibly be sickle cell disease. Or there's this case, this really famous letter that was published in Pediatrics about maybe 10 years or so ago, about a black girl, little black girl that had Tay-Sachs disease. So there was physicians were looking at the film, trying to figure out, well, what's going on? Someone walks in the room and takes the glasses up and says, oh, who's the little girl with Tay-Sachs disease? Well, the issue was that the person who did that didn't know that the child was black. It didn't have that bias. So I guess the question I'm asking you is to think through, and I'm not expecting an answer at this point, but just kind of think through.
One answer that comes to mind, sir, though, is the mean age of people getting multiple myeloma in the European background is 70 years old. Median age is 70 years. In the black background population patients, it's 66 years, 64 years in our population. So I think it would be important, and our patients are mostly female, whereas literature is mostly male.
Well, I think we're going to maybe have a little of this discussion on this question after. I am going to, unless someone has a burning question, I'm going to ask Dr. Ruth to come up and close us out so that we can go and eat.
Let's give a huge round of applause to Dr. LaVeist and our panel. And thank you. I literally have 2 minutes to speak. And panelists, feel free to join your seats at the... Involving community in research and practice is new for many researchers and actually many practitioners as well. It's new for many of us in community health. But community engagement can't continue to be an isolated program requirement. It should be integrated, as the Brooklyn Health Disparities Center is doing through its unique partnership. And NIH has issued a challenge for community engagement, stating that community engagement should be cross-cutting and embedded in leadership, implementation, research, and communication across all levels of our work. So we're building some new metrics for community engagement, and we hope to demonstrate the potential value of community engagement in the range of activities that take us from bench to patient outcomes to community benefit, and that's a lot of what we've been talking about today. And to do this, we have to do several things. First, we need to assure the active participation of community stakeholders in priority setting and decision making. And secondly, we need to be able to clearly communicate at a leadership level the expectations for that community engagement across programs, across schools, across our borough-wide agencies, and at a policy-making level, and assure that there is broad dissemination, which speaks directly to the issue of publication, of the best practices in community engagement. And I was really happy that Dr. LaVeist mentioned that we have to think about other ways of publishing. And publishing is not just through the peer review academic journals, but publishing means using the various forms of media to get the word out about work that's going on, research, how it translates and how it's related to community benefit, and really getting the community engaged in being a part of that communication channel. And finally, we have to continue to challenge ourselves to engage with the most vulnerable communities. And as Virginia Tong spoke today about, that community includes undocumented immigrants, and yes, as Dr. LaVeist mentioned, it also includes formerly incarcerated individuals. And we just have to dig deeper and delve deeper so that we're not missing and everybody is at the table. So I thank you for being with us today. I, again, congratulate all of the speakers for really getting it in terms of the messages we wanted to get to share with you today, and really appreciate you taking the time to spend with us this morning. We look forward to sharing more with you about the work of the Brooklyn Health Disparities Center, and look forward to your partnership with us. And that's the only thing standing between you and lunch. And a very special thank you to our program coordinator, Dr. Pamela Straker.